Good afternoon, one and all. I am Ruby Sound, the co-chair of Special Interest Group of Public Awareness of the PCO Society of India. I bring greetings from the PCO Society of India. On behalf of the society, I welcome all the participants and the speaker for today on this platform today. Let me introduce what is this platform. Under the guidance of Dr. Duru Shah, who is the founder president of the PCO Society of India, we as a team are conducting a series of webinars, rather a series of episodes in 5 different sessions. And these series are called as Vijeta, the winner, means winning over PCOS. Under this initiative, we are doing different programs explaining about what is PCOS and what are the treatment modalities and how you can, go further and make sure you live a life which is free of PCOS or as good as a person who is free of PCOS. We have been doing sessions. In fact, Dr. Duru Madam has already explained you in the first episode about what is PCOS and specifically how it affects fertility. Our entire season 1 talks about fertility. And followed by that, we had Dr. Shobna Patar, who is the chair of this group, who also explained how to diagnose and what the investigations that need to be done. We did not stop on the episode 2. We brought in episode 3, where we discussed about the pre-treatment or in simple terms, lifestyle management strategies, specifically talking about diet and exercise and how you can deal with PCOS by improving these two. Well, we continue from there, and today I'm so happy that I have the legend once again with us, Dr. Dhuru Shah. She has been the brain. She has been the brain behind this initiative, and I'm so happy to have you here today. I'm sure there's a lot of learning happening, and I think the audience is really privileged to hear it from you directly. So, ma'am, we will go ahead with the session, but before we do that, okay, let's quickly understand that the participants who are here, do they know about it? We've got good and very great response in the earlier sessions on this. We'll quickly go through a quiz, okay, and we will repeat the quiz after the session is also over. So this will tell us how much we have learned in the session. So I request all the participants to put your fingers on your mobile and start answering the questions, either in the form of yes and no. The rules of the game is that you will be given about 30 seconds to answer the question. And you will get only one opportunity to say yes or no. You can't change your answer after that. So I request you to read and understand the question very well before you answer. So I request the questions to be displayed on the screen, which you can answer from the time which starts now. Now we have about 8 questions. And the first question is the use of an insulin sensitizer useful in PCOS women? Friends, don't worry. This question will be explained very well in the presentation. But what is your opinion of the use of insulin sensitizers in PCOS women? I see a lot of answers coming in. About 67%, means majority of them so far have said yes, insulin sensitizers are very useful in PCOS women. Last 5 seconds remaining for those who have not answered so far. When only 20% have said, they're not useful. Rest 80% have said. Wonderful. We go to the next question now. Is ovulation induction carried out to help release of an egg to be fertilized by a sperm? So the question is ovulation induction, okay? Is it carried out to help release an egg which is going to be fertilized by the sperm after it is released? So please answer as yes or no. Majority of them have said yes so far. And there's no one who says no to this question. Wonderful. We go to the next question, please. Question number 3 is, do hormones from the brain control the hormones produced by the ovaries? So the question is, do the hormones from the brain, okay, control the hormones which are produced by the ovaries? So is there any connection? Please answer either as yes or as no. We have about 10 seconds remaining for you to answer the question. So far, about 100% of the audience have agreed. No, there are some people who are saying no as well. Okay, there are 14% people who say, in fact, they don't agree to this, but 86% say yes, the brain controls those hormones. Now we go to the question number 4. It says, stress can cause infertility. So is it true or is it false? Stress can cause infertility. That was a very quick response by the audience. Majority, rather 100% of them have agreed that yes, stress is one of the causes of infertility in today's time. We still have about 10 seconds remaining. 5 seconds. And some people have a different opinion on this. Okay, as the time ends, let me share that 89% have agreed that yes, fertility in one of the causes of infertility is stress, but 11% are not very sure. In fact, they say it's false. All right, we'll see the answer after the session is over. Let's go to the next question. Question number 5 is, a woman with a normal menstrual period releases an egg every week or once in every month. So the question is, you must complete the sentence of this. A woman with a normal menstrual period releases an egg. Means how often does a woman with a normal cycle releases an egg? Does she release an egg once a month or does she release an egg once a week? Because menstrual cycle is a monthly affair. So please answer this question as once a month or once a week. Okay. Though 89% have said once in a month, 11% of people say once a week. So we'll come to the correct answer during ma'am's presentation. Question number 6 is, both lean and obese PCOS women need to exercise. The question is, both lean means thin women and obese means overweight PCOS women. Both lean and obese women have to exercise if they have PCOS. Is this true or is this false? Last 15 seconds remaining. Okay. The ratio is changing drastically. Last 2-3 seconds remaining. So the answer here is, I will not say the answer to be very honest. Let me tell you that 86% said yes. Now the next question is, can I go to the next question please? Question number 7. Inositols are deficient in PCOS women. Inositols are deficient in PCOS women. Is it true or is it false? Inositols are deficient in PCOS women. So far, 100% of people have said yes, PCOS women have a deficiency of inositols. What are inositols? Ma'am will be sharing when she gives her lecture. So we have the last question coming up on the screen now. Okay, now the last question says, IUI means intrauterine insemination. Is a very simple procedure which is done in clinic. I repeat the question. IUI or intrauterine insemination is a simple procedure which is done in clinic. Okay, so please answer as yes and no. Today, madam will be discussing about this treatment also, that how easy it is and can it be done in clinic, can it be done on the same day. So far, 71% of people have said that yes, it is simple and it can be done in clinic. And 29% say no, it is not the right answer. So let's see what are the correct answers in the presentation which is coming up. I move further to invite Dr. Durusha ma'am to enlighten the public today, those participants who have joined us today about this topic today. It's an honor and a great privilege for me to introduce Dr. Durusha madam to all the participants who are present here today. As we know that the Durusha madam is the founder president of the PCOS Society of India. Ma'am has been the past president of many societies on the international as well as international societies. And ma'am has received several awards. And in fact, she's also achieved a Lifetime Achievement Award. And she's been a legend in this field. And no one better than madam can explain about this topic to all of us present here. So I request Dr. Durusha madam to take over and kindly give a presentation, ma'am.
Good afternoon. Thank you, Ruby. I hope you all can see my screen.
Yes, ma'am.
Yeah, thank you. Thank you very much for the kind introduction, and thank you very much for moderating this program, which is, I think, something like a Netflix series we are doing. We are calling it Season 1, which is focusing on PCOS women and infertility. So I think we have done almost 3 episodes before, and this is the 4th episode. And today our focus is going to be on what really do we do to manage PCOS for infertility. So as the background goes, that we all know that it's one of the most frequently observed cause of female infertility. A lot of women who have very irregular periods are the ones who nearly get affected. And almost 1 out of 6 women, it's so common that 1 out of 6 women who are of the reproductive age between the age of 12, when they reach puberty till the end of menopause, that is around 50. So between that age group, about 1 out of 6 women would have PCOS. Out of these, 70% of them have irregular periods, and the commonest reason for not getting pregnant in PCOS is because of the irregularity of the periods. Besides that, of course, 80% of women are overweight or obese, whilst 20% can still be lean. So there are many physicians who miss out on diagnosing PCOS. If they find their patient is very slim and thin, they may not sort of go into the details of checking whether she has PCOS or not. And therefore, it's very important to keep in mind that you may be overweight, you may be obese, you may be normal weight, or you may be very lean, where you are underweight. It can be anything out of these, and you can still be having PCOS, which may be the cause of your infertility. And therefore, and it's not necessary that your periods have to be irregular. Your periods may be completely regular. And PCOS is a condition wherein, you really don't know where you stand in short. It's not like a disease which we can say, okay, you have malaria, I give you anti-malarial drugs, and you are treated. With PCOS, we still don't know what causes PCOS. We still do not know we know what are the problems associated with PCOS. We have come to that stage, but we still don't know what is causing the PCOS. And therefore, it's something like a syndrome. We don't call it PCOD, which was called so in the past. There are many patients who are confused about PCOD and PCOS. They say, doctor, what is the difference? Actually, there's no difference. It's just that it was a wrong name given to PCOS prior to us understanding what PCOS is about. So they called it polycystic ovarian disease, but it's not a disease. If it's a disease, like say tuberculosis, typhoid, malaria, those are diseases where we know the cause and we can treat. But when we don't know the cause and the PCOS presents in different ways, there are some girls who are lean, some are overweight, some are normal, some are, sort of underweight. There are some who have got a lot of hair on their face. There are some who are completely clear. There are some who have got acne. Some have got, sort of hair loss from their heads. Some of them have got pigmentation on the neck. Some of them have got irregular periods. Somebody's got on ultrasound polycystic looking large ovaries, while some may have normal ovaries. So it's a mixed pattern. And therefore, unless a doctor sees you, unless you have done the relevant test, you do not know whether you really have PCOS. And therefore, one must remember that if any of these gynecological conditions may be present within you, you need to see your doctor, especially if you're dealing with fertility issues. So when we have a woman who's had PCOS, there are various factors to be kept in mind. Like, first of all, we have to make sure that we reduce the insulin resistance and the obesity in those women. And I'm sure we have discussed insulin resistance before, but just to For people who have not listened to the first session, maybe you could go on the website and listen to all the episodes. You'll understand it so much better. But if you have insulin resistance, by which I mean you are secreting enough insulin in your body, your pancreas, which is a gland in the abdomen which produces insulin, and that insulin is responsible to bring your sugars every time you eat. If you eat lunch, your sugar goes up because you have eaten something and that contains sugar, natural sugar, and the sugar levels go up. A signal goes to the brain and tells the brain that, okay, there's enough of sugar in the blood. Now you need to bring it back to normal. So the brain sends a signal to the pancreas, okay, release insulin because the sugar is going up. The insulin goes into the system, the system where sugar is controlled, and then brings the sugar under control. But there are some women, for some reason, which we still don't know why. These are mainly the PCOS women. They are the ones, they have a problem with their insulin. The insulin gets released, but the insulin is not effective enough to bring down the blood sugar. So the signal to the brain never goes that I don't need more insulin. The signal goes, not enough insulin, come on, go on producing more and more insulin till the insulin starts rising in the blood above normal in order to bring the sugar down to normal. And that high insulin in the body is responsible for the overweight which you develop, or the excessive weight gain you develop, or the symptoms of wanting to eat sweets comes up. Those are the commonest factors. My patients tell me, doctor, I'm craving to eat sweets. And I'm telling her, don't eat sweets. That's the first thing I tell her, stop the sweets. But she says, I'm craving to eat. And that's a very, very common symptom we find amongst our patients who have insulin resistance. The second thing which causes insulin resistance is the obesity. You see, you have a lot of fat in the body, and that fat is usually in the upper abdomen. Like in women, usually women will have a paunch which is on the lower down of the abdomen, which happens usually, if she's had a delivery or if she's gaining weight, it's usually on the lower part of the body. Whilst in men, you'll find the fat is all in the upper part of the abdomen. But when you find a woman with a fat mainly in the upper abdomen and where her waist goes on increasing, that fat is the bad fat. And that fat causes insulin resistance. So in short, in today's days, there are many physicians who believe, why do the insulin levels? They say, if a woman has got so much fat on her upper abdomen, I'm sure she's insulin resistant. And by just looking at her, we would tell her, you need to take an insulin sensitizer, by which we mean you take something which will help your insulin to work better. So this is what we say. We tell women, first of all, to get rid of their extra weight, so start exercising. And even if they lose 10% of their weight, which is extra, that is enough to help them to get pregnant faster. The lean patients are told, increase your muscle strength, because it's in the muscles that the insulin acts on the glucose and tries to bring it down and works better on the muscles. So in short, a lean woman is asked to do resistance exercises like, weight bearing, doing weights, dumbbells, then, sort of doing anything which is, against gravity. So you may be running, you may be doing aerobics. Any kind of such exercise is good for muscles strength building. Then you have yoga meditation, which is actually very good for relieving the stress. Now, why do we want to relieve the stress? Because we know that all the organs in the body, all the hormones in the body are under control of the brain, which sends out signals which sometimes disturbs the whole menstrual cycle. And therefore, being unstressed is the most important thing where, fertility is concerned. So we tell them to do some kind of relaxation exercises which will help them to relieve their stress. Then we come to questions of excessive male hormones. If I've got a patient who's come to me for fertility, I may do all her hormone levels because I know all these hormones affect her pregnancy, affect the success of her getting pregnant. There would be many who will say, why is doctor doing all these tests? There's no reason to do so many tests. I've come to you for getting pregnant. You please get on with it and start my treatment. Yes, I will start the treatment. But if I don't correct your hormones, then you will not get pregnant in spite of whatever I do, number one. Or even if you do get pregnant, there's a higher risk that you may lose that baby. So therefore, let me correct your hormones is what I tell them. So if I find that the male hormones are high, which I will suspect mainly by the acne they have, by the hair growth they have on the face, with the hair's loss on their scalp, all that's suggestive of extra male hormones, which we can to some extent assess by doing the male hormone test. And if I find it's high, I have to give her something to bring the male hormone down. And the best way to do that in a woman with PCOS who's got irregular periods, I would rather give her an oral contraceptive pill, which will help the ovaries to come under control. It will help to bring down the male hormone. It will help to get her periods regular. Again, the patient tells me, doctor, I'm wanting to get pregnant. Why are you giving me a wrong drug? I don't want contraception. I want to get pregnant. But again, I have to explain that when you take the oral contraceptive pill, this is what we'll achieve in the next 2-3 months. And once you've achieved that, we'll immediately start the treatment. Unless you explain to a patient all this, they think you're just taking them down, taking them for a ride. Because somebody or the other will tell them, oh, you're being treated for infertility. Why is your doctor giving you a contraceptive? So in short, it's good to explain to the patient. And we are happy when you, as patients, participate in the discussion, participate in your management. It helps us to treat you better. So ask all the questions you have. It will help you to, understand the problem much better. Then, of course, there are many other hormones which we use, anti-male hormones. But when you're using all those medications, you should not be getting pregnant, because with those medications, it will harm the baby which will start growing within you. So when we give you all these drugs to reduce the male hormone, we do not wish that you get pregnant because it will affect the baby. Hence, those 2-3 months, it's important to bring the male hormone down first and then go on with your pregnancy. The next therapy is metformin and inositols. Now, these are the drugs which are insulin sensitizers, which we'll discuss later. And then you have the oral ovulation inducing drugs. Means these are medicines which helps your egg to come out every month. Women who have got irregular periods do not release an egg every month. They may release an egg in 3 months and then get a period. So their chances of conceiving become lesser only because they are releasing only 1 egg in 3 months compared to a woman who's getting regular periods every month, who's releasing 1 egg every month. And only when you release an egg do you get pregnant. So in short, ovulation induction is a medication which we give to make you release an egg every month. And these are oral tablets which we start with. So this is the first line therapy we start with. And later on, of course, you have other medical, medications which can give. And usually those are the injectable ones, which we will discuss in the next episode. So coming to the weight loss on fertility, definitely how it helps. Now you see this lady's waist. She's got all her fat in the upper abdomen. It's all there and it's so visible. It's not in the lower abdomen, it's in the upper abdomen. And the best way is to measure your waist. If your waist is more than 80 centimeters, then it shows that you have got a lot of fat in the upper abdomen. This is the best way to determine whether you have visceral obesity, what we call, in the upper abdomen. Whilst a BMI, which is a body mass index, measures your height against your weight. And that is also a very good way of assessing, but it doesn't tell you where the fat is. Here, this tells you where the fat is, and that's an important signal. So what we have to realize is, even if you lose weight, even 10% of weight, it helps your periods to come back to regular, normal periods. It may happen after a few months, but it will happen as you go on losing weight. It will help to get you higher clinical pregnancy and live birth rates, less of miscarriages, and it will also reduce the risk of getting diabetes during pregnancy. So very important to lose weight before getting pregnant. These are all the things you have to manage before you actually start your treatment. So when you come to the insulin sensitizers, the two most popular ones are metformin, which is actually a gold standard. It's something which we've been given for last 20 years, 25 years. Whilst inositols is something which has come into the market in the last, say, maybe 8 to 10 years, and we'll discuss these two. If you come to metformin, why am I discussing metformin? Metformin is a medication which is also given to diabetics. And even today, after 15, 20 years of prescribing metformin, I mean, there are patients who say, no, doc, I'm not going to give this to my daughter because I don't want to, give her an anti-diabetic drug. 10 years ago, the pharmacy used to tell the parent, if they went to buy the medicines, they'll ask, who's diabetic in your family? Why are you taking this drug? So people thought that we are prescribing the wrong drugs to the wrong person. And they actually changed the doctor because they thought I'm prescribing wrong. But it's a fact that insulin sensitizer, that's metformin, is the first line treatment for diabetes. I agree. But women are worried to use it because they have a wrong sense. They feel by taking metformin, I'm actually treating diabetes, but they don't understand that insulin resistance is a pre-diabetic condition. And in our country, we are the second largest number of diabetics in the world. So we need to prevent the diabetes coming in. Giving metformin is going to make that insulin work better. Insulin resistance will come down and you'll be able to lose weight. You'll be able to reduce your obesity. So that is one drug we give it to all patients when they are in that phase where they are insulin resistant. And second question they ask me is that, do you think if I take this medicine, my blood sugar will drop? I said, no, it is not known to drop the blood sugar. It only prevents the liver to increase the sugar production. It does not allow the sugar, what is there in your blood, to come down. It won't bring the blood sugar down, but it will prevent more sugar from being produced in your body. So that is very important for everyone to remember, that taking metformin is not going to harm you. It's going to help, if at all, if it is needed. Now, coming to what the global audience says, there are guidelines developed for the whole world, which is developed by the group of doctors of which I'm a part, and these are produced for people all over the world. There are certain changes we make according to the ethnic population, but more or less they are standardized. So the guidelines given these are based on solid scientific evidence. It's not given just because they think it works, but because there is enough scientific evidence. And they say metformin can be used alone in women with PCOS, mainly for helping her to, it's simple. Say I have a patient who's obese and she comes to me, she says, doc, I'm doing so much exercise. I'm doing so much of diet. I'm running on the treadmill. My friend who's next to me is running the same, but she loses weight much faster than I lose. What is the problem? So that's what I have to explain to them. It's your insulin resistance, which is not letting you lose weight. If you start taking the metformin, the insulin resistance will come down and you will be able to achieve your weight loss the same way as the other lady is achieving. It's not about, that the tablet will bring on the weight loss. If you don't exercise, if you don't eat healthy, the tablet is going to do nothing. It will just be taken, ingested, and it will come out. That's it. But if you combine it with exercise, with proper lifestyle changes, it will do you a lot of good. There are a few side effects which go with the drug. There's some mild discomfort, there's some diarrhea, there's some nausea sometimes. So that dosage we have to adjust. And there are some women who just can't take the full dose we want to give. She's absolutely miserable and she's sick. So in that case, we give her the dose, whatever is she's happy with. And then we add on something called inositols. Now, inositols are substances which are found in every normal food. Like mainly you'll find it in grapefruit, in walnuts, in almonds. You'll find it in sprouts. You'll find it in beans. So you'll find it in all this. You'll find a lot of inositols. But they are the lowest in green leafy vegetables. They are the lowest in that. And then in PCOS patients, it has been found that these inositols, which are also insulin sensitizers, which are produced within our body, those are lacking in PCOS women. So PCOS women produce less of inositol within their body. And because of which we may have to supplement them with inositol if they are not responding to metformin, or we can add it as an adjuvant to metformin, or we can tell our patients eat more of these food which is rich in inositol. So inositols are also known to assist in reducing insulin resistance. It helps to regularize menstrual cycles. It reduces acne, improves ovulation. And it can be utilized along with metformin if the full dose of metformin is not well tolerated. The question is that why don't we only use this? Why do we use metformin? Because metformin has been there for many, many years. There's a lot of evidence to show that it works well. With inositol, since it's a relatively new product, I'm not saying new product, but relatively new in the last, say, 10 years. But still, there is not enough research done on it to tell you with confidence that yes, it will work. You get my point? So in short, we all usually, there are different kinds of patients, and depending on the patient, we decide whether to start with metformin or to start with inositol. But one of them we need to give in a large percentage of our PCO patients who may be having insulin resistance. Now, coming to the medical management, I think I want to explain a little bit about ovulation, what is the female reproductive system like, what really happens in the reproductive system. I think this is simple basics of the female reproductive tract. I just want to go through quickly to make you understand how pregnancy occurs. So here we have the uterus, which has got the fallopian tubes and has got the ovaries. There are 2 tubes and 2 ovaries, and the ovaries contain eggs which help with producing babies, and the ovaries also produce the female hormone which is responsible for you to become a woman from a little girl. It helps to develop your breast, your height, your shape, everything comes from here, and all your female, appearance, all that comes from estrogen. Coming to the uterus, the lower part of the uterus is called the cervix, or the mouth of the uterus, and this is the vagina. Now, these are areas of the reproductive system. Why I'm showing you this is because every month a woman who gets a normal period, wherein she's getting her period every 25 to 30 days, any time between that, she releases an egg from her ovary, and that egg is released because the brain sends a signal to the ovary and says, start producing estrogen. As the ovary starts producing estrogen, one egg starts growing from here. That egg starts growing, gets bigger and bigger. When it reaches a size of 2 centimeters, then the egg comes out of its pocket. So it comes out of the pocket, and then it floats around here, and it gets picked up by the fallopian tube. The fallopian tube has got finger-like processes, clamps onto the egg and pulls it within it, and it goes inside the tube. Now, when it goes inside the tube, by the time it lands over here, if a woman has had sexual intercourse and they have not used any contraceptive or condoms, the sperms are released in the vagina. The sperms travel up. They travel up very, very fast. They have a tail which helps them to propel themselves up. And then once they meet in the fallopian tube. Now, when they meet in the fallopian tube, the egg gets fertilized by the sperm, and the embryo starts forming. And after 5 days, the embryo comes into the cavity of the uterus. By then, there is a release of hormone called progesterone, which is from that same follicle from where the egg came out. When it was first releasing estrogen, now it's releasing progesterone. This progesterone, in the meantime, whilst the egg is meeting the sperm over here, this progesterone, which is being secreted from the ovary, is preparing the bed here for them, waiting for the honeymoon sort of, right? Getting the lining ready so that when the fertilized egg comes here, it can find the right spot inside the uterus and implants over there. Once it implants there, then the pregnancy starts. And then it's a journey of almost 9 months before the baby is out. So this is how pregnancy takes place. Now the question is why I discussed about hormones before. Because if those hormones are not in tandem with each other, this egg won't get released in time. The estrogen hormone will not be at the good level, or it may be too high. The progesterone may be not normal, so then the lining doesn't get ready. If the fallopian tube is not good, if it's blocked because of some sexually transmitted disease or from tuberculosis, it gets blocked. Then the egg and the sperm cannot meet. So those are other causes of infertility. But where PCOS is concerned, because a woman is not producing, not getting a period every month, she may be getting every 2 to 3 months. So every 2 to 3 months, she releases an egg. And a woman can get pregnant only when the egg is fertilized by the sperm. So in a woman who menstruates every month, she gets 12 chances in a year to get pregnant. Whilst if a woman is getting 6 periods in a year, she gets only 6 chances to get pregnant. So therefore, the pregnancy rate reduces. In short, what we have to do is try to make sure that we can get this egg out of the ovary every month. That is the whole idea. Now, when we correct the hormones, when we reduce the weight, this tends to happen, and many women get pregnant on their own. Even whilst they are undergoing this whole process of weight loss, we don't do anything. We just give them guidance, and within 3 to 4 months, you'll find that they get pregnant on their own, provided they've been doing their exercises, eating healthy, etc. So this is coming to where the female reproductive system and why in PCOS you are having trouble getting pregnant. One is that there is less number of eggs coming out per year. The second is that if the lining doesn't get ready with progesterone, if there's no progesterone in the body and if there's very low progesterone, then this lining doesn't get ready. And even if the embryo comes here, it cannot implant here and it is shed off. So this is what happens in the female reproductive system. So if you look over here, how the physiology works. I'm telling you all this only because if you understand this, you'll understand what your doctor is talking to you. So here you have a situation. This is the lining of the uterus. This is when the lady has got her period. The lining is shed off during a period. Her lining inside the uterus during the period, the lining gets shed off. It's a peculiar organ. Every month, every part of the month, the lining is different. In the beginning of the month, you'll find that the lining is the thinnest. And as the estrogen levels go on rising in the blood from that follicle which is growing, the lining goes on getting thicker and thicker. You see, this is the yellow line is the estrogen. As the estrogen goes up, it sends a signal to the brain. The brain sends a hormone called LH, which helps to rupture this follicle. And then the egg is released and the progesterone hormone comes into the picture. So it's such a well mechanized reproductive system, so organized and everything controlling the other, that even if you have stress in your head or if you're taking any medication such as antidepressants, they come in the way of you getting pregnant. So these are the things you have to keep in mind, that there may be drugs you may be taking which is affecting this whole hormonal imbalance. PCOS is a condition like this which has effects on the brain, which has effects everywhere in the body. Today we know that it has effects with the gut. Your gut or your system of where your stomach and intestines are also disturbed because of PCOS. So there are various ways in which PCOS is acting in your body, and therefore to bring it under control is most important before you plan your pregnancy. So coming to ovulation induction, as to what really is ovulation induction. Ovulation induction is where we are trying to get one egg come out of the ovary by giving you some medication. Now this is usually done in women with irregular periods because we don't want to wait for 3 months before an egg comes out on its own. And of course, at the same time, we are testing the husband's semen. We are doing the test for the tubes. We are doing an ultrasound of the uterus to check if everything is okay with the uterus, ovaries, fallopian tubes. And we are doing the hormone assays to see if everything is going okay. Now, what you must realize is that every month, when your eggs are growing, it's not, I agree, one egg comes out. But whilst that one egg is coming out, there are many small eggs which are growing along with that egg. And after the 7th day of the period, the dominant follicle, as we call it, there's only one egg which reaches a size of 10 millimeters. Then we say, okay, this is the right egg which will come out. So that egg, as it grows, and then one day it comes out of the follicle. When it comes out of the follicle, you see, these are all the hormones from the brain. I don't want to confuse you all with that, but I'm trying to tell you this, that this is nature. How the other smaller ones are also producing estrogen and helping this egg to grow. Does it happen in daily life? Does everyone get together and help that one person to grow? I hardly see that happening. It's mainly all of them are trying to pull that one down, which we see normally happening in life. If anyone's going ahead, the other one is trying to pull them down. But in nature, these small eggs are trying this big egg to grow and come out of the ovary so that it gets fertilized. it's the best eggs which grow. It's like a race. The best egg will come out. So when you're younger, the best eggs come out first. As you get older and older, the poor quality eggs are left inside. And after the age of 36, 37, it becomes difficult to get pregnant on your own. You need some help. I'm not saying it happens to everybody. It can happen to a large number of women. And today women are going into careers, having babies later. They are having separations. They're having divorces. So it's becoming difficult now. The commonest reason today we see patients who are not able to get pregnant is one is age. Age is a very limiting factor. We can't change it. We can't change the eggs, and every woman is born with a bank of eggs which has this many. Some have so many eggs, some have so many eggs, but there's a limited number. How you utilize them, when you utilize them is important. For a man, there's no problem. He is producing sperms even till the age of 70. But in a woman, I think God has meant it that the woman should not get pregnant after 45, 50 or after 40, because, or usually we see today the life expectancy is higher and we feel women can get pregnant happily till 44, 45. But usually those pregnancies are out of the eggs which have already been frozen before and kept, because a woman has decided, I don't want to get pregnant till this career is in place. And I will use my young eggs later in life to make bigger eggs. But that we'll discuss when we come to IVF. This is ovulation induction, which is helping you to release one egg. So question is that we do this ovulation induction usually with oral medication, which is in the form of letrozole or clomiphene citrate. And then we use ultrasound to monitor how the eggs are coming out. We monitor the patient every 2-3 days, see how the egg is growing, and then decide when the egg comes out. The commonest drug which was used earlier was clomiphene citrate. And almost in about 70 to 90%, we can achieve an ovulation. But the pregnancy rate remains only 30 to 40%, because the side effect of this drug is it causes the lining of the uterus not to develop. And therefore, that becomes a problem. The other oral medication is letrozole, which is better for PCOS patients because it helps the patient. It works better than clomiphene citrate and gets you better pregnancy rates. So if you compare the pregnancy rates between letrozole and clomiphene, you'll find the pregnancy rates are much higher as compared to with clomiphene citrate. Letrozole works better than CC, especially in PCO patients. Now coming to the last part of my talk, where we are talking about intrauterine insemination. Now in this intrauterine insemination, there are some men who have a very poor semen quality. The number of sperms are less, or they are not motile, or the volume is less, or the husband has a problem collecting the sperm, or the problem, or it may be he's got some ejaculatory disturbance and therefore they are not able to have natural intercourse. There are various reasons. So in that case, we do the IUI, wherein we take the sample, we wash the sample, we clean it up out of all the debris or the pus cells, whatever may be present, take only the good active sperms, and if you see here, we inject the sperms here into the uterus, which is done through a very fine syringe. It's no needle, it's only the syringe, and we push it in with a catheter. So it's not painful, nothing, but it helps to bring the sperms closer to the egg. You see the egg comes out from here, goes in the tube as I discussed. The sperms are brought in right in here, and the sperm has to travel a very short distance to reach the egg, which helps the pregnancy to go faster. And the success rate increases from almost 10% otherwise to almost 15 to 20%. So the chances of success will depend at what age you do it, and what is the type of medication you have used, what is the count of the sperm, what is the woman's age, etc., etc. So in summarizing, I would like to say that when we are treating infertility, the first line of treatment is, of course, non-pharmacological. We don't want to give any medications. We only want to correct the hormones and lifestyle interventions, which Dr. Ruby has discussed the last time, about maintaining your weight, maintaining your health, taking the right products, the right diet. Coming to the first line of medical treatment, we use letrozole, or we use clomiphene, or we use a combination of clomiphene and metformin, or we use only metformin, or we use the injectable ovulation inducing agents. Now those injectable ovulation inducing agents we'll do at the next session, because that also requires a lot of explanation, and we'll discuss that later. And in that next session, we'll do that. In the last session, we will be talking about IVF. So coming to my key messages for today, it depends, the key to successful treatment depends on the reduction of your body weight in PCOS. 100% it works. And if it's a lean patient, she must do muscle strengthening exercises. Dietary intervention, increased physical activity is very important in obese women. It reduces your insulin resistance, it improves the menstrual regularity, it increases fertility, and it helps to lower the male hormone. Lifestyle modification, I told you, in lean PCOS, also better outcome after exercise. And the waist circumference, how many inches you lose on the waist, how much is your BMI getting lower, helps you in achieving pregnancy faster. So weight loss is sometimes we are asking the patient to lose weight. As I told you, we are giving her all the support, making her lose weight. She may get into spontaneous pregnancy also. She may not even require any medical treatment. It's definitely lower in women who are older than 35 years, especially in the obese PCOS women. Oral ovulation inducing agents help by bringing on the egg out of the ovary, and egg quality and fertilization is definitely reduced in PCOS patients, and implantation, clinical pregnancy rates and birth rates are definitely higher in women after treatment. So in short, I would like to say this, that concluding my talk, I wanted to explain why it is important for you to correct everything before jumping into trying to get pregnant. Thank you very much for your kind attention, and I'll be available for any questions you may have.
Thank you so much, ma'am. It was really an eye-opening talk, I would say, and very, very simple. I'm sure all the patients will not now need to go back and check my doctor has written this medicine and go and check on the Google what is this medicine and get confused whether I have diabetes or whether I have PCOS. And thank you so much for talking in details about what is a female reproductive system, how the hormones change throughout the month, and how these hormonal tablets we are giving and why they are given basically. What hormonal imbalance are we going to correct? Especially about metformin, ma'am, I think it's been, very, very helpful to understand the role of metformin in PCOS. Let me thank you so much for your enlightening talk. I think we will go ahead with the question and answer sessions. I can see some questions in the chat box. In fact, I request all the other participants that if you have any questions based on what ma'am has discussed so far, please feel free to write your questions in the Q&A box and we will answer in next 10 to 15 minutes. Requesting you to post in your questions. Ma'am, there's one question in the audience. Miss Anita is asking, I have been taking Yasmin for last 3 years and I'm going to get married in the month of November. Do I have to stop taking Yasmin? Because it's an oral contraceptive, is what I was told when I started.
Yeah, I think if one is taking Yasmin, it's an oral contraceptive. It's important to have a medical checkup at least once a year to make sure that everything is okay with you. Every medication, if it's taken long term, will have its side effects or complications. So it's good to at least see your gynec, make sure that what you're doing continuously for last 3 years, is it safe for you or not? It's very safe to take it, but you have to consult your doctor at least once a year and make sure that there's no other complication going on. But one thing you have to remember, if you have polycystic ovaries and you're taking the Yasmin, it helps to keep your ovaries under control. So in those cases, we like to continue the Yasmin till you're ready to get pregnant, because that will keep all your hormones under control and it will help you to get pregnant faster as soon as you stop the tablets. So if you say, okay, I'm getting married in November, I would suggest to you see your gynae. Since 3 years, I'm not sure whether you've seen your gynae or not. Get all your hormones evaluated, make sure it's safe for you. Continue it if she says so. Continue it till you get married and till you don't want a kid. Keep doing your test once a year. And after when you're ready to have a baby, stop the oral contraceptive. Now, there's one little disadvantage which can occur from this, is that if you've taken it continuously for many years, then sometimes it lowers your AMH. Now, AMH is a hormone which helps to assess, what are the number of eggs in your ovaries. So you get a false low reading. So don't get alarmed, because when you have taken Yasmin for 3-4 years continuously, or any oral contraceptive, it suppresses the ovary to some extent, which we want in a PCO ovary. But in a normal ovary, sometimes what it does, it suppresses the ovary, and then the ovary takes time to start functioning again. It's like, if you have got everything ready made on a platter sitting at home and you don't need to work, why will you work? You sit, enjoy a royal life, eat what you want, put your legs up, sit on the beach, have your drink, and you get food ready served to you. You've got all the money to spend. Why should you work? So similarly with the ovary is getting its hormones from outside. Why will it work? It will stop. It won't stop. It will go to sleep. So you'll have to give a break period for that ovary to come out of its sleep. So therefore, it's important that once a year, at least take a break for a month and see your doctor once a year. Make sure that it's safe for you to continue. That's all I would recommend.
So I think, Anita, you need to go back once for your assessment and evaluation before you decide when to stop and when do you want to plan a family. Thank you so much for that answer, ma'am. Ma'am, there are two questions, basically more or less similar. One participant is asking, are there any side effects of these hormonal injections? And the other question is, will I gain weight due to these hormonal injections?
Totally wrong. No hormonal oral contraceptive makes you put on weight. That's the myth which is existing. I think women like to find a reason for blaming their weight gain. Usually they'll say, "Oh, I had a baby, so I put on weight." Fine. After the baby's out, you lose weight, right? Or they'll say, "I underwent surgery, so I put on weight," or reasons like that. And I think there may be reasons where women may put on weight. I'm not denying that. But at the same time, 90% of the time it's because of lack of exercise or lack of controlling the diet. So it's important that you must know that it's not the hormones which are making you put on weight. There's an excellent study done by the WHO where they took 5,000 women and they gave them oral contraceptive pills who were on contraceptive pills and 5,000 women who were not on the pills. And they compared the weight of all these patients, and then they came to a conclusion that it's not the pill which is making them put on weight. Hardly 5% put on weight because of the hormones they were taking, whilst 5% of them actually lost weight because of the hormones, whilst 90% maintained the weight as it was. So I think this is a myth that you put on weight because of hormones. There's a little bit of a water retention. There may be some water retention, but that is hardly a kilo or two. And that usually you'll see premenstrually, if you weigh yourself, if you're say 50 kilos before your period you're 52, post period, you'll find after 4-5 days, you'll find your weight has come back to 51. So it's more water retention than actual weight.
Okay. Okay, ma'am. Thank you so much for that answer. Because also, if you're exercising regularly and if you're on a good healthy diet, then I think you should not worry about the side effects of these hormonal injections, especially weight gain. There's a question from Kamarjit Kaur. Is it normal to have 2 days of bleeding in a menstrual cycle for a girl with PCOS?
It's normal to get a 2-day cycle. There's nothing wrong, but it's possible that there may be some associated hormonal disorders also, especially if the period is, most of the times what happens if the period is delayed, it comes after 2 months, you will find the patient has got a very heavy period. But if a woman has got a period coming normally every month and only thing is this lighter than otherwise, then you need to know whether there's any other reason because of which it is lighter. It could be sometimes a hormonal disturbance. It could be a small cyst in the ovary. It could be so many factors. It could be some medication you're taking. So if your period has been the same right from the beginning, you have been getting a period, say, every 35 days, your period lasts only 2 days. If it's been like that right from the time you've been getting your periods, then you shouldn't worry. But if there's a change in your pattern, it was 2 days before, now it's become 1 day or it's become half a day, then you need to see your doctor. If you are from 2 days, you've become 3 days or 4 days, then see your doctor. So it's a change of your normality. Each one has its own normal period style. So that is what is important to remember.
Okay, ma'am. And we have a lot of questions. I will take as many as possible due to paucity of time, but some very, very useful questions for others as well. There's a patient who's asking, my age is 40 and my husband is 45. How many cycles of treatment should we try before we decide for IVF? Probably some doctors must have suggested IVF, But I think after listening to your talk, they must be finding other alternative treatments.
No, the thing is, if you're 40, the lady is 40.
Yeah, my husband is
If
40.
she's 40, then you see the egg quality is diminishing. So if the egg quality is diminishing, then you want to catch hold of whatever best eggs you have at that point in time. Because as I said, that as you age or as you grow older, after the age, Indian women reach menopause by 48 or so. 10 years before that, their eggs start going for a toss. So that your results of getting pregnant come down drastically. Whilst American and British women and all, they get their periods at about 52 or 53. So their ovaries, sort of pack up around 42. So what we have to remember that we are reaching menopause about 5 or 6 years earlier than other women. And therefore, by 37, we should be trying to complete our families. But if you're 40, don't waste time with routine treatment. I think we should go after assessing one cycle, making sure your hormones and all are okay. Go for the best form of treatment for yourself so that you get pregnant as fast as you can. Otherwise, you'll end up with taking egg donation. That's what will happen. So I would recommend a very, very quick treatment.
Yeah. So I think if you want to know more about IVF in the subsequent episodes,
Yes.
we will be talking about IVF in detail. So I request this participant to come back and hear what is IVF, when to do it, and how the treatment goes about. So I request you to come back and join our next sessions. The question, for a girl recently diagnosed with PCOS, is it more appropriate to implement lifestyle modifications alone or combine lifestyle modifications with metformin? And I mean, this is a dietary question, which I think I answered last time. She's asking about milk intake with girls with severe acne problem.
So you're talking about a young girl who's how old?
Nothing more is mentioned, just a girl who's been recently diagnosed with PCOS. Is it more appropriate to only put her on lifestyle modifications or both lifestyle as well as metformin?
It depends on how bad or how severe her obesity may be. If she's got a lot of obesity, then I would like to give her metformin along with lifestyle changes. But if she's mildly overweight, I would encourage her to start with healthy, lifestyle and see how her response is. If I find after 3 months that she's not losing weight the way she should, depending on her diet and her exercise, then I would definitely add metformin.
Okay. There's a technical question. I think she's a doctor, Dr. Bindu. What is the recommended dose of minoxidil? 4 grams or 2 milligrams?
4 grams a day.
Okay. And I think I'll take only 1 or 2 questions because we have to conduct a poll questionnaire also. But this question, I think many of them ask that I am a full-time working woman. Okay. If I'm going to start the fertility treatment, is it going to affect my job? Do I have to quit it?
She doesn't have to stop her job. I think, I find there are many women who are stressed when they are doing their job and wanting to reach the doctor, because you have to go to the doctor more frequently. And therefore, you're fighting between your job and, and the stress which it causes. So in that case, it's better to take a little break, ask for some leave, go on leave, and then finish that whole evaluation and everything in that 1 month so that you know where you stand. But if it means that you're going through an IVF treatment or you're going through a treatment where you feel it's possible for you to go 1 hour late to work or it's possible for you to work from home, then there's no need to quit jobs. Because in those cases, I find when they're, especially women, whom we have already done the IUI or we have done the embryo transfer after IVF, they are waiting for 2 weeks for their result. Now that 2 weeks can be very, very taxing for those women because they're constantly thinking it's like a young student, will I pass, will I fail, will I pass, will I fail? Some people, will I get the medal or I won't get the medal? There's stuff like that. So here the women who have undergone treatment are constantly worried, will I be pregnant? So it takes their mind off that if they are working. So it's important, which stage of the cycle you're saying. If it's in the beginning when they are going constantly to the doctor, they may take a break for a few days, take leave. But when they have had the implantation done or they've already done the IUI, next 15 days, please go to work so you don't sit and worry about the result. That's what I would say.
and start reading and watching videos on PCOS on the website www.pcos.org. You will get to see a lot of informative videos. Educate yourself with the correct information. Don't get lost in this Google world and get the wrong information from influencers and non-medical professionals. You have the
Correct.
50 to educate yourself and be rest assured that today or tomorrow you will get positive results. I think I will not take any more questions because some questions are pertaining to IVF cycle. I will request them to come back to the next episode to know more about IVF. I think, ma'am, you've answered most of the questions. And let me now see that after hearing all the, all the questions and going through the entire presentation, is there been any change in the knowledge of the participants? So I will quickly run through the post-poll. The same questions which were asked earlier will be asked now. Ma'am, I request if you would like to conduct this post-poll session yourself, ma'am.
Okay, sure. Can I have the first question, please? Yes. Okay. The first question is use of an insulin sensitizer. Is it useful in PCOS women? Let's get the answer quickly and see where we are. There we are, 100%. No no's at the moment. So we said when we did the first pre-poll, it was 80%. Now it's 100%. Next one. Next question. Is the use of we finished with the first question. Can we have the second one? Is the use of an insulin sensitizer, is ovulation induction carried out to help release an egg to be fertilized by a sperm? So ovulation induction is used to help release an egg, which is then fertilized by a sperm. Let's start the poll. Nobody wants to answer. 100% say yes, ovulation induction is used to bring an egg out of the ovary so that it can be fertilized by the sperm. Perfect answers, all 100%. Previously, we had yes. Even then, we had 100% answering yes. And now we have 100%. So no change at the moment. Everyone knew everything all before we started on this subject. Next one, please. Do hormones from the brain control the hormones produced by the ovary? Yes or no? Can we have the answers, please? 100% answering yes. Initially, it was 86% answering yes. Now we have all 100% convinced that hormones from the brain are definitely controlling the hormones produced by the ovary. And there's no better way to know that, when you're stressed about something, it definitely affects your periods. So we have gone to a yes of 60% compared to 40% post-poll. That means what I spoke did not go through well. When I talked about hormones controlling the brain, yes, coming to stress, can it cause infertility? We talked about it during the session, whether stress can cause infertility. So again, 100% say yes, whilst this is question number 4, and previously 89% had answered correctly. Now 100% are answering correctly. We go to the next one, number 5, post-poll question number 5. A woman with a normal menstrual period releases an egg. Something's gone missing. Every month or once a week? Once a month, once a week. What is correct? She releases an egg once a month or once a week. If she's releasing it once a week, she can get pregnant every week. How do you like that? The answer is wrong. Once a week is not correct. The egg comes out usually on the 14th day of the cycle. It meets the sperm on the 14th day of the menstrual cycle, but counting the menstrual cycle from the first day of the period, on the 13th or 14th day of a 28-day cycle, that's halfway through the cycle, an egg is released. And if the sperm, she meets the sperm, and during that period, within 2 days, then only a pregnancy can happen. But if there's no intercourse within those 2 days, then she's not likely to get pregnant, and therefore that whole month there's no chance of another pregnancy. So it's usually one egg released a month, and if that during those 2 days, because the egg dies a natural death after 2 days. So if there's a sperm already within her body, a sperm can survive within the body for almost 6 to 7 days. So in short, if the sperm is already in her body and the egg comes out and meets the sperm, yes, pregnancy can happen. But if there's no sperm and she's released an egg, she's not had intercourse for the next 2 days, then she can't get pregnant. So therefore, we tell couples nowadays where husband is sitting somewhere else and wife is sitting somewhere else, we say, please plan your work schedules in such a way that you're together during the time when you're likely to get pregnant. That is between the 11th day of your cycle to the 18th day of your cycle is your fertile week. Stay together so to get pregnant. Next slide, please. Both lean and obese PCOS women need to exercise. True or false? So both lean and obese need to exercise. That is the question, whether it is true or false. So 100% say, I don't know why people are answering wrong. 20% say, initially it was number 6 question, 82% were right, and now it is 86% were right. Okay. Next question. Go to number 7, please. Inositols are deficient in PCOS women. So is it true or is it false? %, correct, which was initially also 100%. So the answer is correct. Inositols are deficient, and therefore if you give inositols during the treatment, it may help in improving the menstrual regularity. Next question. Intrauterine insemination is a simple procedure done in the clinic. So is that yes or no? It's a simple procedure done in the clinic, intrauterine insemination, where the sperm is washed, put inside the uterus through the vagina and through the cervix. So here 100% right answer. Initially it was 71%. So we have a majority of our listeners who have been more or less better off after the session in some of the questions, and in some of the questions they haven't done so well. So their knowledge hasn't improved in that. Whilst we'll make sure we will be conducting another panel discussion after about 2 more episodes. At that time, you'll have all the physicians available to you. At the same time, you can come up with your case, ask your questions related to your own individual situations. So that will be a panel with the endocrinologist, with dermatologist, with everyone to answer all your questions. So we'll be doing that a little later, and I'll ask Ruby to take over, please.
Thank you so much, ma'am. This means the audience was very attentive. They've answered, but only those who are lazy and their patients are lazy, they have said that exercise is not important for lean people. So I think that is that is the simplest question of the quiz. So exercise is very important, whether you're thin, whether you're that is lean, or whether you're overweight or obese. You must exercise. The type of exercise I discussed in the previous session. So exercise is important. Rest, I think they've understood the presentation very well, and they've all changed their opinion after seeing your presentation and hearing one. And thank you so much for sparing your valuable time in educating the people at large. It can really bring a big, big change in the society. And I think this is what the PCOS Society is motivated to do all the time. That is to bring awareness among people and break all the myths about PCOS Society, whether it is fertility, whether it is diabetes, or, the other issues that can happen or come up in a woman with PCOS. So I thank you, ma'am, from the bottom of my heart. And I'm very, very happy that PCO Society has brought this series. And this is only with the support of Philips that we are conducting this program. And I also want to formally thank Dr. Shobna Pathak, who is the chair of this special interest group on public awareness, with whom I work very closely in bringing these episodes to you. And all this is not possible without the support of the entire team of Vijeta, who have been working, at the back end, technical team, and the coordinator who is constantly working and helping us bring this program to all of you. If you have any more queries, please write to manager.vijeta.pcos@gmail.com. We will answer all your queries. And if you want to know more about the PCOS Society, please visit the website, and there you can find more educational videos and more programs which come up regularly on the channel of the YouTube channel and the Instagram page. Let me invite you to yet another interesting session, okay, about PCOS treatment, the second line of treatment, where we will be talking about ovulation induction in details and the other modalities of treatment. And that program is going to be moderated by myself, and Dr. Durusha Madam will be once again with all of us to discuss in details. And we will meet once again on the 29th of March in the afternoon between 3 to 4. We will be sharing the exact title and the details of the program in the next 2-3 days so that you can share the link with all your friends, colleagues, sisters, and others who can learn more about PCO Society. So without further ado, I once again want to thank Duru Madam. And if you want to say something before we close the session for the today.
No, I just want to say thank you to everybody for being with us, and those who have missed any of the sessions will be able to view the sessions on our website. I think if you can flash the website address, it would help to for them to see. They'll see it also on our YouTube channel. The programs will be put up on our YouTube channel. So if you can display those, it will help.
I will also share a link with them so that they can directly log in through their phones.
Yes,
with the click of a button. We will direct them to the page that will help them. And we are very, very, we welcome all the comments, and you can write to us. If you can't reach out to us, we'll be very happy to help each one of you. So once again, thank you everybody for being with us. Such a lovely weekend, and hope we keep learning more and more together. So we join back after a couple of days to go one step ahead and learn more about PCOS. Once again, thank you so much, and have a great, great, great weekend ahead. Thank you so much once again.
Thank you, Ruby. Thank you so much for doing such a good job. Thank you.